Thank you, Dr. Nisnik. Our next speaker is Dr. Anuj Bhargava, who's a native of Ottawa with deep roots in our community. He pursued his undergraduate degree in biochemistry, medical school, and residency training in ophthalmology at the University of Ottawa, and then went on to complete a fellowship in cornea, external disease, and anterior segment surgery at the New York Eye and Ear Infirmary in Manhattan. And then following his first year of practice in Cornwall, he's been in private practice in Ottawa for the past 5 years. He has a general ophthalmology practice, but also specializes in cataract and corneal transplantation surgery, and he also sits on the executive committee of the University of Ottawa Eye Institute. Please welcome Dr. Bhargava.
Thank you very much, Mark. Bonsoir, mesdames et messieurs. I also want to thank the organizers of this meeting and for inviting me to join such an esteemed group of colleagues who've done so much over the last few months to raise awareness about the impact of these funding cuts on the future of healthcare in Ontario. So as we've heard already, these funding changes are going to have wide-ranging consequences across all specialties of medicine, and ophthalmology is no exception. Now I want to personalize this a little bit so that you can understand how you as an individual and how patients will be directly affected by this. Now, to understand the impact in ophthalmology, one has to understand which diseases are these changes going to affect. Well, the commonest causes of blindness in Canada are macular degeneration, glaucoma, and diabetic retinopathy in age-related people. And all of you have probably heard at least of one of these diseases. And these are things that we deal with each and every day. And the funding changes which have been introduced, some of which have been proposed and others which have already been introduced, are going to affect the way in which we can detect, monitor, and treat each of these diseases. Now let me give you a few examples. There's a test called an OCT, or an optical coherence tomography. This is a very sophisticated, high-tech piece of equipment which uses a laser-based technology to detect glaucoma and macular degeneration in the very earliest stages. This is very expensive technology and tests that we need to order to do our jobs appropriately. Well, there's been a reduction in the funding for this test by almost 66% in the last couple of years, to the point where we can no longer, or the fee no longer covers the cost of buying the machine, maintaining it, staffing it. So as ophthalmologists in private practice, we can no longer offer this service to our patients. And this is the standard of care. This isn't some premium service. We're not paying for plastic surgery. This is standard of care. This is what we need to prevent people from going blind. And I've had this discussion with several patients about how this is going to affect them and how this technology is very expensive. And some patients have flippantly said, well, why don't you just send us to the hospital? We'll get it done at the hospital. Well, it may not be common knowledge, but most hospitals don't own this technology. This is standard of care. Certain hospitals in Ottawa, such as Civic Campus, the Queensway Carleton, the MO4 where I work, they don't even own this equipment because it's very expensive for the hospitals to purchase it, let alone staff it and maintain it. They've put the onus on physicians to buy this equipment in order for them to provide the best treatment to their patients. So, I've spoken to, there's 2 campuses in Ottawa where we can get this test done. One is the Eye Institute, or the general campus, and the other is the Riverside. I've spoken to the technicians at both, and they're already overwhelmed with the volume of tests that they're doing. So if the other 40 ophthalmologists in town were to send all their patients to the hospital, these tests will never get done. I mean, we're going to have a 10-year waiting period for something that has to be done in a timely fashion so that we can prevent our patients from going blind. So that's just one example. Now, not only has the ministry already decreased the fee for this service so that we can maintain these machines in our offices, they've also reduced the number of tests that we can do from 6 to 4. And what's really frustrating for most of us is that the Minister of Health has repeatedly said that all these changes are based on the best available medical evidence. Well, I can assure all of you that as an academic ophthalmologist, someone who keeps up to date with the medical literature, as all my colleagues do, goes to conferences, that there is no medical evidence anywhere in the Canadian scientific journals, in American publications, in international publications, that supports only doing 4 tests a year. And in fact, to the contrary, Canadian guidelines and American guidelines for the treatment of macular degeneration indicate that these tests have to be done almost monthly in some patients. So now we're faced with the point, we see patients going blind from macular degeneration. We know that we have to monitor them every month to make sure that our treatments are effective, but the government's not going to pay for it. So how will these patients get their tests done? You know, if we can no longer afford the equipment in the offices because we're doing them at a loss, and I can tell you some of us who are in practice are already taking a loss. Every time we perform the test, we're paying for it ourselves. The government isn't paying for it. So that again, you know, just illustrates how we're going to be practicing medicine. Just to echo what Dr. Nisnik said, we're going backwards. We can treat macular degeneration the way we did 30 years ago, but do we really want to? I mean, thousands of people have preserved their eyesight because of these advances in technology, and we'd like to maintain that standard of care, of course. Another test that we do routinely is a visual field, which helps us to monitor the progress of glaucoma, which is another potentially blinding disease, which is irreversible if it causes vision loss. Well, if the self-referral cuts that Dr. Nisnik referred to come into play, again, the cost or the fee that will be paid will be below the cost of purchasing and maintaining the equipment. So for those of us who are already in practice who are absorbing the cost, well, perhaps we'll continue to do so, but I can assure you new graduates who are coming out are not going to set up practices that are going to be money-losing propositions. And so it's going to make Ontario a less attractive place for new graduates to practice, and that's just a fact. Now, apart from diagnostic testing, one other issue I'd like to bring to your attention, it's not just diagnostic tests and revenues to our offices that's going to affect the quality of care. When it comes to cataract surgery, for example, and how much the government is willing to pay our anesthesiology colleagues to perform services with us in cataract surgery ORs, they've reduced the fees for anesthesiologists so much that in some centers, anesthesiology will no longer be able to provide sedation for patients who are going for cataract surgery. This is a serious issue. You know, the ministry will have us believe that most people can have cataract surgery under oral sedation and that the surgeon is miraculously going to do the surgery, monitor the patient, if there's a problem, somehow treat the patient at the same time. It's just not practical. You know, most patients can have safe surgery under oral sedation, but you know, I was operating today in Winchester and I'd say at least 5 out of the 10 patients required a higher level of anesthesia. They may need IV sedation, even general anesthesia. You know, these are patients who have anxiety disorders, dementia, language barriers, tremors, you know, patients with developmental delay, a Down's patient. It's impossible to do cataract surgery on a patient with Down syndrome under local sedation. They have to be put to sleep. So by effectively removing anesthesia, and unfortunately in Ottawa this hasn't affected us as much because you know, we have a center like the Riverside where one anesthetist can monitor 4 rooms, but in smaller community hospitals, that's just not possible. And so there's a ripple effect and how one specialty is going to affect the other. And you know, we want to do our job in a safe manner, provide quality care to our patients. And essentially, you know, I see sort of the quality of care that we're being able to, or allowed to provide, just slowly eroding. So this first round of cuts, it may not seem like much, but you know, we all know what's coming down the pipelines, and it's going to have bigger consequences down the road. So I encourage all of you who are as concerned as those of us on the panel about this to, you know, contact your MPP, contact the Minister of Health, Mr. McGuinty, and you know, just tell them how concerned you are, and that you know, future changes in the system should be brought about after negotiation with the OMA, and to speak with the stakeholders, people who know about how to deliver quality care. And we all understand the financial situation, but we want to make sure that any changes that are brought about don't affect the high quality of care that we've come to enjoy. So, thanks very much.